switch gears a little bit. We're still obviously talking about immunity, but now we're gonna switch over to hypersensitivity. So, now we're looking at more like allergies, allergic reactions, things like that, which we know we can have all sorts of different types of allergies. Not everything is like peanut butter is trying to kill you, right? We can have just like skin contact, like topical allergies. If you're anything like me, you've never had to deal with being allergic to poison ivy. My husband, ironically, who works in forestry, could like be near it. Hey, what are you doing? What are you doing? Hello. Seeing people.
Wow, y'all the night cohort?
Yeah.
Wow, all three of you.
Yeah.
I was day cohort.
Did you vote? Did you vote?
I did two
Okay.
votes, yeah.
Okay.
Did you get all of them?
I haven't told them yet. You know, they don't know me like that.
Well, just let me. Bye.
Bye. I'll talk to you later.
Now we know.
My child is in this competition to be a junior ranger. Y'all know Jeff Corwin? But what I was saying is my husband works in forestry and he can just like be anywhere near poison ivy and it get all over him. So, looking at latex allergies, anything that just like comes in topical contact basically is what we're looking at with skin contact. Then we have injection. Now this is me right here with mosquitoes. I could be in an igloo in Antarctica and a mosquito would bite me, I promise you. So this is more of like your bee stings, mosquito bites, ant bites, things of that nature. Ingestion, you either have to take it by medication or swallow it like by a drink or food. And then go over to the inhalation, you breathe it in. So mold, mildew, dander, cat hair, pet hair. I think I may have told y'all, I told my children that I'm allergic to cats, but I'm not, it's just because I hate them. And I don't ever want them to ask for one, so we're gonna roll with it. Dust, things of that nature. So you see, some are gonna be, like pollen falls under both, right? Pollen is gonna be one that, you know, you could get some on your skin, it could cause like some irritation, itchiness, that sort of thing, but also, I mean, we live in the South, y'all been here in March and April, right? We all come in here sniffling because of the pollen. When we look at reactions and like allergies in this sense, then there's a few process or a couple of steps to it. So when y'all think about being allergic to something, let's say, I just always default to peanut butter because it's easy. But if someone's allergic to peanuts, was it the very first time that they had peanuts that they had a reaction to it? Most likely not. It's the second, right? Because we had to introduce it first. We're not just naturally introduced when we were born to peanuts, right? And so they get introduced to the peanuts. Their body is like, oh, that was weird. Didn't like that. We develop antibodies against it. And then the next time when they're exposed to it is when they potentially have the reaction. Which I didn't know that until I was in nursing school, because I was like, why does everybody freak out about giving babies something for the very first time? You know, because a lot of times it's the second time that they're exposed to it when they might have an actual response to it. When we look at how they react to it, and this is pretty self-explanatory, but we know we can have immediate reactions, right? As soon as a mosquito bites me, I see the bite, I'm itching, it's really annoying. Then we can have people that maybe even eat shellfish, and then it's like a little bit later, they're like, like, you know, maybe my throat's a little itchy. That's still kind of considered the immediate because it's already starting in those first few minutes. When we look at our delayed, it's more so like when you get your TB skin test, remember we have to wait at least 48 hours. It's 48 to 72 hours to read that because it takes at least that 48 hours to potentially be able to tell if you're having a reaction to it or not. So that's gonna be more of your prolonged. We talk about a little bit of transplant rejection because that's gonna be over time, right? That's not gonna happen instantly unless it's a true circulatory like blood supply issue. Contact dermatitis, we know that maybe you change your face wash and it's a few days before you start to notice a rash that develops, or maybe your face starts breaking out, whatever it may be. Your immediate is more so what we're looking at for your anaphylaxis, which we know is bad, right? Surely everyone's aware of that. latex allergy is one that's really common, especially in healthcare workers. If you think about it too, we have a lot of healthcare workers that develop latex allergies because they're exposed to it so much, right? Now we have a lot of nitrile. We kind of pull away from a lot of the latex in some areas because we found other things that we can use instead. But there's also a cross allergy to bananas and kiwi and avocado. If y'all have gone, I don't know if she works dinner, but at East Alabama in the, yeah. I was gonna say, I don't know if she works dinner anymore. You can't even come her line with a banana, right? Because she swears she's definitely allergic to it. I've gone through her line with a banana before and she was fine, so. So every time I think about this, I'm like, I bet she's probably allergic to latex too if she's so allergic to bananas. But if you do have a latex allergy, typically it's more of like what you more commonly see is like more of a contact dermatitis reaction. You see like some irritation. People will wear like a latex glove, and then when they take them off, they have like their hands are really itchy. They have redness, maybe little raised bumps. And then it can also go all the way in severity to an anaphylactic reaction. So, you know, when I think there's frequently a common misconception when you see like a latex allergy listed for a patient or someone that you're like, oh, they just can't wear latex gloves, they can't use latex condoms, whatever it may be. And you think more of like a skin reaction, but it actually can be deadly. I mean, it can range all the way up to anaphylaxis, just depending on how their body responds. You see, roughly estimate of about 700,000 healthcare workers that have a latex allergy, which again is a little bit easier to work around nowadays than it used to be. So, when we're looking at that delayed, which we talked very briefly about with like our TB skin test, looking at like that 24 to 72 hours after exposure, it could be longer. This is just kind of a good window of reference to use. And sometimes this is also, it's not necessarily just the mechanism of your reaction to it, but sometimes it's because you're having a prolonged exposure to it, right? Like when they do that TB skin test, it's not like you just come in contact with it once and then it goes away, right? You come in contact with it and then it sits there under your skin. So you're having a more prolonged exposure to it, so it's obviously going to be able to like kind of fester a little bit, if you will. Contact dermatitis, so think about coming in contact with different makeup, skincare, cleaning products, soaps, all the different things, lotions, poison ivy, things of that nature. Sometimes, you know, people, even if they do have an allergy to poison ivy, they can like brush up against it once and maybe they'll get like a tiny little spot, but then they have to like really spend some time in it for it to actually create a larger response. Most of the time with all this contact dermatitis, they're gonna have the redness, the itching, and the thickening of the skin. They might get like some raised bumps. Not always, sometimes it's literally just red and itchy and kind of scaly, like you'll change the texture of the skin a little bit like rough, but not necessarily prominent bumps. These are just some really simple pictures of some examples. You'll see this one, like, that obviously isn't changing, like you're not getting bumps or anything here, but you can see that someone was clearly having a contact dermatitis reaction to the ring, right? And then over here, this is probably a little bit more texturized. Sometimes, you know, especially like in the bend of the elbow, maybe people might think that it's eczema, which eczema is kind of a type of contact dermatitis in a way, not really, but, and so it can vary. And it can be just a tiny little spot or it can be widespread. So sometimes contact dermatitis is like, I'm terrible, like my friends will send me pictures of rashes on their kids and they'll be like, oh, what's this? I'm like, I don't know. Contact dermatitis. It's always my go-to. I'm like, I don't know, call the doctor, not me. But it is, and sometimes unfortunately we use it a little bit as a scapegoat because it does cover such a wide range of things, right? And often, a lot of times we just need to stop putting on it what caused it and then give it some time to just chill out and heal a little bit. Other times we can put some topical stuff on it to speed the process along, but a lot of times it's just a trial and error of figuring out what made it react that way to begin with. Good question.
Yeah, this might be stupid, but
No,
can a delayed, reaction turn into anaphylaxis, or is that very not likely?
I would say not likely, not impossible. Yeah. Okay, so atopic reactions. These are inherited sensitivity to allergens, so think of like your allergic rhinitis. Those are typically seasonal. Your atopic dermatitis, which is more so what your eczema falls under. That, eczema can come and go. You have flares. The reason that some people try to loop eczema in with the contact dermatitis, even though it's technically atopic, is because sometimes it's flared up because of what we put on our skin, because of the contact that we use, right, by the soap or whatever it may be. And so that's why sometimes it can people use that a little bit more interchangeably than we probably should. You can have urticaria, which is just like hives, fancy way of saying hives, which hives are a little bit different than like a welt from gets like slapped, right? Like you can have a welt that's the shape of whatever it was that hit you, where it kind of raises the skin momentarily. And then hives are gonna be a little bit more spread out. They're gonna be raised, they're typically gonna be pink, they itch, and they'll be widespread usually. And then angioedema, which is where we have that swelling that's a little bit deeper down into the skin. That's all in our face. So you can imagine, what's the fear there?
Aspiration.
Well, even before aspiration. Airway, right? If my face starts swelling up, I'm a little concerned, right? Because I don't know where it's gonna go. Now, does it always go to our airway? No, absolutely not. Sometimes it just stays, like you get really puffy eyes, like your cheeks get really puffy, your brow bone like becomes one solid feature, like there's no definition, right? But obviously, this is something that's telling us like, hey, there's something really wrong. It's not necessarily saying their airway's gonna close, but it's definitely something I'm gonna watch a little bit closer, right? And then it can also go down to the hands and the feet, and the larynx as well, which is important. If that tongue starts to get involved is really when I'm concerned. Because usually if my tongue starts to get involved, then the larynx is soon to follow. And that's when we really, really start being even more concerned with the airway. Now, if my lips and my eyelids are swollen, I'm gonna go ahead and assess my airway, right? Because you've gotta have it, right? I can live for a little bit with my eyes swollen shut. Can't live a little bit with my throat closed, okay? So, how are we gonna manage them? I would venture to say everybody in the room has at least one, or let me back up actually. Let me talk about anaphylaxis here. So, with anaphylaxis, what do you do to treat it? Okay, epi, what else? Benadryl, what else? Fluids, you're gonna do epi, you're gonna do fluids, you're gonna do Benadryl. Benadryl is what? What kind of antihistamine? It's an H1, okay? So then, in combination with that, we also need to block H2, right? Anybody know an H2? What about famotidine or Pepsid? It's an H2, so we're gonna give Pepsid as well, or famotidine. And then we'll also probably give some steroids. So you'll probably give like methylprednisolone or Medrol, whatever it is. We'll give that IV. So you're gonna have your epi, your fluids, because we need to make sure that we don't go into like a vasoconstrictive shock essentially. Benadryl, famotidine, which Benadryl is diphenhydramine, okay? Famotidine, and then you're gonna have your methylprednisolone. If you suspect that someone is going into anaphylaxis, what's your main priority? Yeah, so this is where I want people to use their brain. We were talking about like questions earlier. If I have someone that I know is developing some lip swelling, they had some throat tingling after they, ate oysters, and they come in, what's gonna be my priority? Giving them epi or assessing their airway? assessing their airway. Yeah, I wanna know what's going on first, right? Now, is my epi getting administered basically at the same time? Yes. Can we do two things at the same time in a test question? No. Okay, but I need to know what's going on with them right now. I need to know if that airway is okay or if it's not, because that's also gonna tell us a lot about what's actually going on. Because maybe they do just have some lip tingling, maybe we can get away with just doing Benadryl and some Pepsid, right? So assessing, always gonna be your first thing. Even if your patient does not, like if you see on the monitor that they're flatline, are you just gonna go in there and start cranking on their chest? No. You're gonna see if they have a pulse first, right? You're gonna see if they're just sleeping and knocked their left lead off, okay? Always gonna assess, okay? So, how are we gonna manage them? Big thing is, we're gonna stop doing whatever it is that we're allergic to, right? If you're allergic to peanuts, don't eat a Reese's. Pretty common, right? One of the biggest issues, I would never wanna be an allergist because I feel like you just have to guess it so much and just like throw the kitchen sink out and see what sticks. But they go through extensive allergy testing a lot of times to figure it out. Some of y'all may have been through allergy testing. Most of the time they do it like on a patient's back. And they do small pricks of common allergens. And then you're not allowed to like sweat, you're not allowed to shower for however long.
3 days.
Yeah, there you go. And then you go back and you see what you've reacted to, which sounds miserable. I've thankfully never had to have it done, but like if I'm reacting to something that's itching, I'm gonna be cursing whoever made me go through that, right, for 3 days. So, they go through allergy testing, do it.
See the video where a girl was like, she was allergic to everything they tested her for,
Yeah.
her face is.
Yikes. Yeah. Bye. There was somebody there, I promise. Not gonna come to the other door.
We just talked about that.
So I'm like, Dr. Darden lectured on this anyway. No hallucinations here that I know of. I don't know, I guess I wouldn't know. You're real to me, okay?
We will not argue with you.
Yeah, don't argue with me. Therapeutic communication, all right? So, not necessarily my strong suit. So, when we find out whatever it is that's causing this, we also just, common sense, right? Avoid it, okay? If you find out that a certain soap makes you break out, don't use the soap. I'm sorry that you already paid for it. Let somebody else use it, throw it away, I don't know. And then when we're looking at more of like our environmental stuff, maybe delegate cutting the grass to somebody else in the house. You know, like if that's making something flare up and things like that. Yes, ma'am.
So if you're allergic to something, well, let's just say my daughter's allergic to horses. And we have
Oh,
our
poor
horses.
thing.
And she just keeps, she doesn't know better, and they do
Yeah.
it a lot of times. So if you keep going around something you're allergic to,
Yeah.
it's making it better or worse.
Well, so I would, to be safe, I would say that probably depends, because there also is exposure therapy that some allergists use, especially as your immune system matures, and as you develop more histamine, because like I have a friend from high school and he was like deathly allergic to peanuts when he was little, and then by the time we were graduating college, they were starting to reintroduce peanuts to his diet. So as he got older, now he wasn't continually exposing himself, but some allergies you can kind of grow out of. Sometimes with things like animals, like with pet dander and things like that, then if it's not severe, some people just ignore it because who would want to stay away from all animals all the time, you know, kind of thing. But I would, to be safe, I would say, I guess in some ways it could potentially make it worse, but I would anticipate that you would see that getting worse, you know? I don't think it would take a really long time for you to notice that it was making it worse, if that makes sense. But also sometimes people, like if, sometimes they think that they're allergic to like, I'm just using that as an example, like horses for instance, but sometimes it's the hay that they're around.
Oh, no,
that
she's
they're-
allergic
yeah.
to horses.
So you see that sometimes with people too, like they think it's one component of whatever they're around, but it's actually something else. They just don't realize that they're coming as much in contact with it, by passing by. So when we're looking at more of like our airborne allergens, like I was talking about with the cutting grass, let somebody else do it. We can also do like some consistent antihistamines, like maybe we need to take something consistent like Zyrtec or things like that when we're at a high risk of coming in contact with stuff, which we know just calms down that histamine response, tells our body to chill out a little bit, that sort of thing. And then desensitize, which is kind of what we were just talking about. That is one thing that some doctors are able to do, and that's gonna be patient specific from what I know. Some patients respond a little bit more to desensitization and exposure therapy than others. I saw this one girl on TikTok that she was allergic to a lot of stuff, and she was doing the exposure therapy, and she would go and they would literally give her like a pinpoint amount of peanut, and then she got to sit there for like 2 hours. I was like, wow, that sounds terrible. And then like a week later, she came back and they did like 2 pinpoint amounts of peanut. Like it's it's very gradual to make sure that you're not having that reaction anymore. But sometimes that happens with age, and other times I would imagine maybe the repeated exposure probably helps too. All right, so antihistamines. Oh, okay. Look out. Remix. We have lots of different ones. So we have first generations, which is where your Benadryl falls. You also have your chlorpheniramine and your clemastine. Those are ones that pretty sure those cannot be found over the counter. Y'all can fact check me on that if you click the link. But all of them can cause some drowsiness, unless you're my oldest child, and Benadryl makes you bounce off the walls. So it has the opposite effect. And then it's also, they act as anticholinergics, which we know is what? What's the? Yeah, it dries you up, right? Like a raisin. We wanna make sure that we're considering the fact that we don't want them to drink alcohol while they're taking these. We don't want them to drive heavy equipment. Maybe an excavator is not the vehicle of choice if you're on Benadryl and that sort of thing, because you might be drowsy, your reaction time might be a little bit slower because some of that drowsiness is happening. And then you switch into your second generation, which is when you see your like loratadine and your cetirizine, which is your 2 more common ones, the fexofenadine, which is Allegra. I feel like you used to see a lot more, like, I think maybe just because they had the big commercials. Now I feel like Claritin has probably taken more of the commercial space, but, and then Astelin as well, Azlastine. That one, I feel like we see some in the hospital, but not quite as much as the others. Similar side effects and that sort of thing, it's just their second generation instead of first, okay? And really that just means we came up with some before the others, for what y'all need to know.
They don't cause a drowsiness though.
Not as severe, and some of that is gonna depend on, patients, but ideally, they do not. But they still kind of have some of the same warnings of like, oh, it may, it's not supposed to, but it may, but sometimes they just do that because the way that side effects work with drugs is if it happened to one person and it was reported, it has to be included, which seems like a confusing system, but that's the way that they work a little bit. All right, and then we can also do some decongestants. So decongestants is more of like when you know that you're gonna be in contact with like environmental allergies and that sort of thing, then you may see some of these used as well in combination with your antihistamines. So pseudoephedrine or Sudafed is one of the more common ones, and then ephedrine as well. You have to be really careful if a patient has hypertension with these. They can actually cause worsening hypertension. Now they have some that you can take specifically if you do have hypertension, but they're not as, like Quercetin is one if you've seen it. That's one that's safe to use if you have high blood pressure, but they don't have quite as much of the effect that these do when we're looking at more like this allergic response and that sort of thing. Want to make sure that we're not increasing or keeping a really high amount of caffeine use with these. And then Afrin and phenylephrine, or oxymetazoline, which is Afrin. I don't know about y'all, my dad used to live on Afrin, before he had a sinus surgery. It's a little nasal spray, if y'all have seen it. You're not supposed to use it as much as he used it, for sure, because you can have that rebound vasodilation, if you use it every single day, which he did for years. So if they do use those and it does help, then we wanna make sure that they know that they can't just use it all day, every day. You're gonna use it for like the short amount of time that maybe you're exposed or you're really having some symptoms, and then we're gonna take a little break. And then we're gonna use it maybe again if you're exposed again to something, and then we might take a little bit of a break, okay? Any questions here? No? Any questions in general about all of the immunity stuff? None? Alright, give me like 10 minutes or so I can switch gears and get some of the sensory stuff pulled up. If y'all have had the chance to look at that, which I would imagine maybe you haven't, because I know y'all had those tests yesterday. But if y'all wanna take a few minutes during that break, if y'all have any questions, kind of jot it down. And so then that way we can kind of make sure that I'm answering some of those questions. We've got plenty of time, so I'll talk about some of it. I'm just not gonna do like a full into all the details lecture, okay? It's gonna be about 10, 15 minutes and then we'll switch over to that.